When I initially, when I wrote this, I think it was a couple of days before I posted it. So as we're going to go through it and talk about it for a few minutes, but I just want you to be aware that the date that I have might be off from your date by a couple of days, simply because of when I did it. Okay. All right. So before we do that, how was clinical last week? Any issues, concerns, problems? I think everybody was okay. I checked in. I think everybody was okay. I checked in with Professor Field. I'm going to ask Professor Press group to I just have one follow-up question for you. If you guys can just wait a few minutes after class, and I'll just get the information that I need from you. But I think everybody else was okay.
Yes.
Survived it. The case study, I hope, offered you an opportunity to start pulling together all of the pieces of information that you're gathering, some things from fundamentals, some things from psych, certainly from the first 3 lectures that we've had, 3 or 4 that we've had. Okay, so let's talk about our friend Catherine, if I can find her. I've already got too many things open. You will check the Khan Academy video, but do not get too lost in it. The main point is for you to refresh your memory from what you learned in AMP. I know a lot of you took AMP some time ago, and you might not have paid as much attention to the reproductive stuff as I would have liked you to, because, of course, I want this to be like forefront in your mind, but I know it's part of a whole course. All right, a couple of facts. So the placenta has a rough texture, and actually I don't have my picture here. I'll see if I can bring it up on the break, but the placenta has a rough texture. It has a red, rough texture on the maternal side and a shiny, more smooth gray appearance on the fetal side. Okay, so it's one way. If you're just looking at a placenta in a bucket, how you would know which side you're looking at. So remember that the placenta has 3 functions: metabolic function, transfer function, endocrine function. We've talked about the endocrine function as far as secreting hormones. We've talked about the transfer function, oxygen, nutrients, waste products back and forth from the fetus and to the fetus. And it also serves a metabolic function in that it does produce some carbohydrates. But the transfer and the endocrine are the main 2 that we will talk about. Okay, it also transfers some immunity, passive immunity, and I can't remember when we're going to talk about that, but we will talk about that at some point. All right. So umbilical vessels, remember there are 3 vessels, 1 vein, 2 arteries. And yes, I do expect you to remember that and to know that. Remember that the umbilical cord is the lifeline for our fetus, for our embryo, the lifeline. So starts out as an embryo, becomes a fetus, but it is the lifeline. 2 arteries, 1 vein. Blood flows through the umbilical cord at 400 to 500 mils per minute. Rapid, rapid, rapid flow. And it is crucial, as we will talk more about this today, and especially tomorrow. I want you to keep that in mind. So the umbilical cord, you have the vessels inside, the 3 vessels, and then surrounding the 3 vessels is this gelatinous material that is called Wharton's jelly. So Wharton's jelly, as I said, is gelatinous, a little bit spongy. It helps prevent vessel compression, helps prevent kinking of the cord. And again, that's going to be important as we go on to talk today and tomorrow. The umbilical vein carries oxygenated blood to the fetus from the placenta. The umbilical arteries carry deoxygenated blood from the fetus to the placenta. It's a little bit opposite than what we're used to, but this is important to remember as we go forward talking about labor and delivery, okay? All right, so any questions about the placenta, the umbilical cord before we get to the fun stuff? All right.
But can you just go back for 1 second? I just want to finish writing. Thank you.
Okay. Okay, so here are some abbreviations that I would like you to add to your abbreviations sheet that I posted. I didn't give it to you. I usually give it out, but I didn't give it out this time. Didn't have it with me. Okay, so NSVD, you will sometimes see this written as SVD, spontaneous vaginal delivery. Cesarean section, cesarean birth, you will see that abbreviated in a couple of different ways. EBL, you will hear, you're going to hear that a lot from now going forward, and certainly when we talk about postpartum next week. So the typical EBL for an NSVD is 500 mils. Typical EBL for a cesarean delivery, 800 mils to 1 liter. Okay. So I'm going to start off talking about cesarean birth and then move into vaginal delivery because there's just a lot more to say with the vaginal delivery. It's going to be longer. So we're going to start off with a cesarean birth. So one of the things that I did tell you that you need to review is, I forgot the chapter number, I think it's 40 something in your Potter and Perry regarding post-op care. That's going to be important when we get next week when we talk about postpartum. So today we're talking about the birth, but I know we have the exam on Tuesday, but make sure as part of your unit 2, if you need to go back to Potter and Perry and review some things about post-op care, that you do that as part of your unit 2 review. Okay, so cesarean birth. Cesarean birth is it's a surgical procedure. It is a surgical procedure, and as such, it requires a medical indication. It requires a medical indication that the fact that October 26th is good for your schedule, is a good day for you to deliver this baby, is not a medical indication, okay? Now, having said that, I realize that we can always find a physician, and you know, I hate to say this, but we can, it is the truth, we can find a, you can always find a doctor to do whatever you need or to write whatever note you need. That is just the reality, but this is a surgical procedure. It requires a medical indication, all right? So just because today fits into your schedule is not a medical indication. All right, so medical indications. You will recall that last week, I think, I said to you that TOCIA, TOCIA, that kind of speaks to labor. And you know that dys is difficulty, right? Like dyspnea is difficulty breathing. So difficulty with labor. Dystocia speaks to some sort of difficulty with the labor process, okay? That is an indication for cesarean delivery. CPD, and that's an abbreviation that you should kind of get in your head, because I will not often say cephalopelvic disproportion. Much more often, I will simply say CPD. So that is an indication. So what are we talking about with CPD? What does that look like? It means
The head of the baby.
the head. So cephalo is the head, and whose pelvis am I referring to here?
The mom.
The mom's. So it is just what it looks like. The fetal head and the maternal pelvis are out of proportion. So the fetal head is too large to pass through the pelvis. So you will recall last week, and I think the week before as well, we talked about the size and shape of the pelvis and how important that was to a vaginal delivery, to the likelihood of a vaginal delivery. Hypertension risks, depending on what's going on with the mom, and we'll talk more about that when we get to complications. So hypertensive risk can also be an indication. Other maternal medical conditions, again, we'll talk about that then. Active genital herpes. So if there are lesions, visible lesions, a cesarean delivery is an indication, that is an indication for cesarean delivery, active genital herpes. Now you'll have some practitioners who will opt to deliver by cesarean, even if there are no active lesions, as long as the patient has a history of herpes. And the reason for that is that there can be very, very small lesions that they might not be able to visualize, and they don't want to take a chance on the fetus contracting a herpetic infection during a vaginal delivery. If the patient has had previous uterine surgical procedures, so for instance, one of the things that I mentioned about Catherine is the possibility of fibroids, right? So let's say this is a mom who had fibroids removed. If she's had a uterine surgical procedure, even though this might have been some time ago, the fact that the uterine muscle was incised makes it vulnerable to rupture during an attempted vaginal delivery. And we're going to talk more about that today and tomorrow. So there is a risk for patients who have had previous uterine surgical procedures, whether previous cesarean delivery or some sort of uterine surgery, the risk that that incision site might rupture with the stress of labor. So that is an indication for cesarean birth. Okay, so let me ask you this next one. Let's see if I can see more faces here. Persistent, non-reassuring fetal heart. What did I write? Fetal heart pattern. Does that sound like a good thing?
No.
That in and of itself. Now that's going to make more sense to you tomorrow, but that in and of itself should sound like a not such a good thing. All right. So that is an indication for a cesarean birth. In a situation like that, a persistent, non-reassuring fetal heart pattern is just what it sounds like. We're very concerned about what's happening with the fetal heart. And so there may be the need to get this baby delivered, to get the baby out of the fetus delivered, to get it out of a distressful situation. Prolapsed umbilical cord. This is when the umbilical cord presents before the fetus. Remember that the umbilical cord is the fetal lifeline. So if that is presenting before the fetus, that is extremely problematic. Fetal malpresentation, we'll talk about that today. This is,
Professor Silvia, what does it mean before the fetus? So it comes before the umbilical cord, then the baby?
Correct. The umbilical cord is coming out before.
This is just a big deal because it's getting pinched off with all the pressure, and then
it's not getting pinched off. It's getting compressed, right?
Oh.
So yes. So what you need is the fetus to come out first. Remember that it is the lifeline. So if the fetal lifeline is delivered before the fetus, what's keeping the fetus alive while the fetus is still inside? Okay. Fetal malpresentation. So if you can just visually imagine, typically we usually have the fetus head down or head up. So malpresentation, we're talking about a fetus that is what we call a transverse lie. So the head is on the left and the feet are, let's say, on the right. All right. So the fetus is horizontal. Okay. And we're going to talk about that today. Obstetrical hemorrhagic conditions we'll talk about when we get to complications, but there we're talking about things like placenta previa, abrupted placenta. So conditions that are causing maternal hemorrhage. And those very often are emergent situations. So I don't think I gave you this slide. I just wanted to give you an example to see a little bit of what I'm talking about. This is an example of umbilical cord prolapse. You can see the cord is presenting before the fetus. Cephalopelvic disproportion. The head size is too large for the pelvis. These two are conditions of, what did my slide say? Obstetrical hemorrhagic conditions. So this is the placental abruption. This is placental previa. This we're going to talk about, as I said, tomorrow. We'll definitely talk a lot about non-reassuring fetal heart tracings. And you are going to be, by 1 o'clock tomorrow, you all will be experts in reading these strips. This is an example of a fetal malpresentation. You can see this is not going to be a vaginal birth, right? Okay, so just to give you some examples. So placenta previa, looking at this, what's your concern here?
Placenta's in the way.
So I want more specifics. You're correct, Fred, but I want more specifics. So you guys help give me some specifics, help Fred out here. Give me some details.
The placenta is blocking the cervix, the cervical opening.
So the cervical os, right? Yes, you're right. You're right, Valentina. Don't say it with a question. You're right. It's blocking the cervical os. The placenta is blocking. Ruth, you were going to say something?
Yeah, it should be by the fundus part, facing the fundus
Right.
part, because
So the
that's
ideal placement for the placenta is in the upper uterus and in the posterior aspect of the upper uterus. But here we have a placenta that is implanted in the lower segment of the uterus that is in fact covering the cervical os. So in this case, a vaginal delivery is not happening. It's not like, oh, there's, a 10% chance. It's not going to happen. All right. So how would we know that this patient had placenta previa?
through ultrasound.
An ultrasound.
On ultrasound. So remember last week when we talked about doing ultrasounds to see what is in the uterus and where it's positioned, what the location is, what the condition of it is. This is one of the things we look at, is where is the placenta implanted? Okay, where is it implanted? And we'll talk about previa, as I said, in Unit 3. Contraindications. So, contraindications for cesarean birth. Fetal death is a contraindication. And so I know that this is hard to hear. It's not much easier to say, but when there is a fetal demise, if the fetus dies in utero and a delivery has to be induced, because that has to be delivered. If the delivery has to be induced, it is induced to happen vaginally, okay? It is not an indication for a cesarean birth. And so I know students all the time will say to me, oh, that's so heartbreaking to have a mom, you know, she already knows that the fetus has died and then to have to deliver it vaginally, and I totally get that. But from a medical standpoint, it's actually a little bit safer for her to do that vaginally than to do it by cesarean delivery.
Why?
So, because there are many more, remember that you have the complications also of a surgery. So there are just more complications that are possible with a surgical procedure. So fetal death is not an indication. Okay? An immature fetus or a premature fetus is not an indication unless you're dealing with one of these issues like a persistent non-reassuring fetal heart tracing, or the mom's health is at risk. Then you might actually deliver by cesarean delivery, even if she's only 34 weeks, she's only 32 weeks. You might have to do it in order to preserve the life of the mom and the baby. If there are maternal coag defects, we tend to be very cautious because, again, surgery, you're incising flesh and causing more bleeding that can get out of control. Okay, so usually we try, if we don't have to do this, we try not to. So risks, if you look at the list on your left, maternal risks, with the exception of urinary tract trauma, this list could apply to almost any surgery, right? These are basically your basic post-op complications: infection, hemorrhage, thrombophlebitis, paralytic ileus, atelectasis, complications of anesthesia, pneumonia, which would fall under infection. All of the common post-op complications, in addition to urinary tract trauma, and I think that will make sense to you in a few slides. Fetal risks. There is the risk of inadvertent premature birth if we don't have clarity or we're not sure about the dates. If there was a miscalculation, we might deliver a 36-weeker by cesarean delivery that was calculated to be 38, to be a 38-weeker, but is in actuality a 36-weeker. So there can be an inadvertent premature birth. Transient tachypnea. Just see, I think I just have, yeah. So the full name is transient tachypnea of the newborn, TTN, and we will talk about that when we get to newborns. Persistent pulmonary hypertension of the newborn, that can happen also due to cesarean birth. Traumatic injury to the fetus during the procedure. So some of the things that we need to do in preparation, preparing our patient for surgery, some of this you would do for any pre-op patient. And again, a lot of this is what you covered in fundamentals, but I'm going to just make it a little bit more specific to our prenatal patient in preparation of cesarean delivery. So options for anesthesia for a cesarean birth, we're going to talk about pain management and epidurals next week. But I'm just going to put in the chat box the main 3 options. So there's general anesthesia, epidurals, spinal, CSC. And again, we'll talk about those in detail next week. But just so that you know, there's got to be some anesthesia, right? This is major surgery, so there will be some anesthesia. Typically, we use general anesthesia when it's an emergency. If there is at least a little bit of time to plan and to organize, we tend to opt for either an epidural, spinal, or you'll see I put in the chat box the CSE. That is a combined spinal epidural. And exactly what that is, hold off until next week. I don't want to, that's a unit 2 thing. I don't want to overburden you. So epidural, spinal, combined spinal epidural. Those are your basic options, and general. Those are your basic options. So you need to do all the prenatal labs that you would do on a pre-op patient, plus the specific ones that we have talked about, specific to maternity, things that we're interested in. A VTE assessment, so venous thromboembolic assessment. What is this patient's risk for developing DVTs? So we do this on all pre-op patients now. So at least we know going into surgery, which patients are more likely to develop a DVT, so that we can be proactive about that. We need to obtain IV access and administer IV fluids. We'll talk more about that after we deliver the baby. We're going to talk a little bit more about some of the exact nursing care things. Pre-op meds. So I'm going to ask you to put in the chat box what pre-op meds do you think a patient will need, with the exception of antibiotics, because as you can see, you already have on your list prophylactic antibiotics. So with the exception of that, what meds might a patient need? This patient is going for cesarean delivery. So I want you to, so I see 2 things here. So pain management would fall under anesthesia, right? That would be taken care of with the anesthesia. Be careful with anti-hemorrhagics. Remember, you're going to be incising a patient. So while you may be thinking to give an anti-hemorrhagic, you don't want to either give something that can cause bleeding or can cause clotting, because the patient's already at risk for DVT.
Mhm.
Remember what we talked about prenatally and the increase in clotting factors. So this is a pregnant patient. She's already at risk for DVTs, even though we have the hemodilution going on. So you want to be careful with that. You would only give an antihypertensive if the patient has a history of hypertension. So you don't want to go into surgery with your blood pressure out of control. Again, an analgesic would be for pain management, but that would be managed by the anesthesia. Stool softener you would give post-op. So we're still pre-op. We haven't done the surgery yet. You guys are getting ahead of me. We haven't done the surgery yet. Stool softener, acetaminophen, those might be after. Why is she at risk for DVT? She's at risk for DVT because remember what we talked about. Pregnant patients increase their clotting. All clotting components increase during pregnancy. So she is at risk, okay? Pregnancy is a hypercoagulable state. An antacid. So Alice, why might we give an antacid?
Sorry, that's my microwave. I'm so sorry. I was thinking because there's like a lot of, it's an abdominal surgery, so there's going to be a lot of the stomach acid, and it might like make its way into other parts of her body where like it shouldn't be.
So, but think about it. So yes, it is an abdominal surgery, but we're not, it's a lower abdominal surgery. So we're not really, we shouldn't be near the, well, it's usually lower. We shouldn't be that close to the GI tract.
Okay.
Right? So, but you are right about an antacid. That's the thing. So I just have to take that in. We got to go another direction with that. Okay. Heparin, remember what I said, heparin, while you might be thinking to give heparin as a preventive for the prophylactically to prevent DVTs, remember that we're going to incise this patient. So if you give heparin, heparin will make her more likely to bleed. You're going into surgery, you're going to be cutting into tissue, incising tissue. She's going to bleed more. So there's got to be a balance there. All right, so going back to this antacid, I want you to, what are your concerns when a patient goes to surgery? What are your concerns about the patient other than like DVTs and hemorrhage? What else are you concerned about that this patient might?
Breathing.
It's for aspiration.
Okay, so Fred, you're concerned, and Jinhee, you're concerned about aspiration. What are you worried about?
If she starts to, like nausea is common and vomiting is common. So if during all the heavy breathing and all that kind of stuff, that comes up and then she takes a breath in, I mean, that could be bad news.
In general, Professor, like at the surgery, you have to stop eating whatever, like one day before or something. So this is considered a surgery. So of course, the food.
So I agree with both of you. Yes, and you're absolutely right. Aspiration is your concern. I want you to think about what is it that you're concerned about her aspirating. And that's a question for all of you. What is it you're concerned about her aspirating? So she's been NPO. Let's say her surgery was at 9 a.m. She's been NPO since midnight. So chances are there's nothing in her stomach, right? But what's in there?
There are acids.
The stomach acids. And that is what you're concerned about. So what is the pH of gastric secretions?
2 something.
Below
It's
3.
right. It's acidic, right?
Oh, yeah.
So I want you to remember that if that's your concern, so if she aspirates that, the damage that will do to the lung tissue, okay? So again, when I'm telling you, I want you to be more specific and really think about things to the end, okay? So yes, it is, aspiration is your concern, but I want you to know why. So she may aspirate those acidic secretions and that will damage the lung tissue, okay? So with that in mind, yes, we need to give an antacid. So Alice, that's the reason for your antacid, okay? And what else might we consider giving? What other type medication might we consider giving? The concern is aspiration. So you want this to not happen?
Like an antiemetic?
An antiemetic, right. So you might give, depending on the practitioner's preference, you might give one, you might give both. So I want you to keep that in mind when you think about pre-op meds, okay? Other than whatever else the patient might need if she's hypertensive or, whatever. But an antacid, an antiemetic, okay? And why you're giving it. Remember, anytime you give a medication, you have to understand why you're giving it, all right? Okay, so those are your main pre-op meds, your prophylactic antibiotics, skin prep, and then inserting a Foley catheter, okay? All right, incision types. There are 3 types of incisions. And the incision that is on the abdominal wall has to correlate with the uterine incision. So remember, it's not just one incision and boom, the baby is out, the fetus is born. No, there are layers. So there's what happens on the abdominal wall and then what happens to the uterine wall. Okay, so 3 basic types of incisions. So in answer to your question, Palavina, it's, again, you have to have some sort of anesthetic. More than likely, you're going to give a prophylactic antibiotic. And as I said, it's the practitioner's preference whether you're giving an antacid and or an antiemetic. Some of them will give both, some will give one or the other.
I have a question on the classical incision. Since the baby is transverse, why aren't they doing a transverse cut? Like either
okay, so, and Fred, don't take this the wrong way, but I have to correct this. So yep. Students that are in my class always laugh about this, but there will be no cutting and no shooting. We're not giving patients shots, we're giving them injections, and we're not cutting anybody. We are incising, okay? So you got to speak the language to get it in there, right? Okay, so so in the lower picture, that's the one you're looking at, the classical.
Correct.
So I think when we go a little bit further, that might make a little more sense to you, but let me just say the condensed version is that incision gives more space. And when you have a fetus that is in transverse lie, you need more room to get that fetus out. Okay, so that's the short mini explanation for now. Okay, so again, your abdominal wall incision needs to correlate with the uterine incision. So if you have a patient that has let's say a vertical abdominal wall incision, that patient will more than likely have a low vertical incision. That patient, you're not going to see like this on a vertical incision on the abdominal wall and a low transverse on the uterine muscle. Okay. So I think I gave you this slide.
Yes, we have those.
Slide,
yeah, we have both.
Which are the same as this shorter one. It's just they're a little bit bigger, so you can read them a little bit better. So I think this is abdominal wall. Yeah. Okay.
Professor, sorry, the vertical is not more for the emergency, or it's just the size?
Verticals are usually done more for when the procedure needs to be done more quickly, like in an emergency. Yes. So, so the gentleman may have an idea of this as well, but for the ladies, this Phenensteel, this low transverse incision is known as, come on ladies, you know what?
GD line.
It's the bikini cut, right?
Yeah.
The bikini cut. That is what's commonly called the bikini cut. So we'll have patients that come in, they may have a medical indication for cesarean, and they will very often come in and tell you exactly what they want, what sort of incision they want. But the reality is the incision is going to depend on the clinical scenario. Okay, so a patient that comes in and says that she wants the bikini cut, but the fetus is in a transverse lie, we need more space to get this fetus out. Because if you just look at it in terms of maneuverability, you can see that a fetus that's positioned like this, you need a larger incision. An incision like this is not going to give you enough space to get this fetus out.
Professor,
my question was
is not going to get this fetus out.
Like I understand that it needs more space, but the baby is transverse. So why isn't the line there transverse.
Why isn't it this
size.
way?
Yeah, same size.
Oh, because yeah,
it
it does not. The incisions have to be in line with, because remember, it's not only what's going to work in terms of getting the fetus out, but it has to work in terms of the body, in terms of the anatomy of the skin and of the muscle.
Yeah.
Yeah.
Thank you.
You're welcome. Sorry, I misunderstood your question. So basically, I want you to read through these just to have an understanding, this slide and this slide, to have an understanding of the advantages and the disadvantages. Am I going to ask you very specific questions about this on the exam? Probably not. But you should understand how this impacts on the healing, how the procedure is done, and what the maternal status is going to be postpartum and on the healing, okay? It's important for you to understand that, right? And of course, the risks. So things like this incision, this vertical incision, has a greater chance of dehiscence and hernia formation. So while you might need to do this for a diabetic mom, she's already at risk for wound dehiscence, right? So you need to keep those things in mind. So you understand what I'm saying? I want you to really start to understand that so you can pull that together with the other pieces. The issue here with this low transverse incision is it cannot be extended. So if this is the incision, and then once the procedure starts, you have but so much that you space to incise here. So this incision just gives you more maneuverability. Most patients don't like this because it's not aesthetically as pleasing. This one, especially on the abdominal wall, is more concealable, okay?
Is a hidden.
So my take, honestly, I always tell patients, you want the incision that is going to be best for you and the baby, right? You want the best possible outcome. Whether or not you end up with an abdominal scar can't be the priority right now. But I get it. I do, you know, on the other hand, I understand that. But it's important that whatever is done needs to be done for the health and safety of the mom and of the fetus. Okay. All right. So you can see with the low transverse incision, remember on this slide, I mentioned that the possibility of uterine tract trauma. So think about where the incision is. So when you see, or maybe on this slide, you can see it better, how there's a risk. This is the bladder, urinary bladder. There's a risk that the urinary bladder can be nicked during the procedure. Okay, so there is a risk of urinary tract trauma. Okay, well, we got one baby out, right? But that's not the baby that we're more worried about. It's our vaginal delivery that we're more concerned about. Now, I want to just point something out that I didn't even think about before, but how would you characterize this baby's feet? Like you can really see the baby's right foot. What would you tell me about that right foot?
It's underformed, yeah.
It's what?
Underformed?
No, it's formed, but it's flexed, so you can't really see.
Okay.
It's hyperflex.
The
Right?
reflex.
What else? So yes, it's wet, it's flexed, but it is.
It's swollen.
Finger are long. The toes, they
What
are
about
long,
them?
too long.
Hyperextended.
Well, they're flexed.
Yeah,
But there's something else I want you to tell me.
there is a reflex when they
So it's
are
not
like,
about the position of the foot, though.
They're
Don't-
purple.
it's the reflex to the position, how they are, no?
Not about the position. I don't
They're
want,
purple.
it's not, my question is not about the position.
It's
When you
purple.
look at that foot, what is the first thing you see?
The foot is purple.
The crease down the
The
center.
the color. That's the first thing you saw. But most of you bypassed that, but you saw that, didn't you? You all saw the color, but you bypassed it. You went to flexion and the toes and all of that stuff. Think about everything that you're taking in. Remember on the first day, I said to you, your assessments are very detailed and you're not conscious of some of the things that you're assessing, okay? Everything that you're seeing, everything that you're hearing, everything that you're touching, that you're feeling. You saw that the toes were discolored, but you went right past it, all right? I'm going to come back to talking about this tomorrow. This is called acrocyanosis, and it is perfectly normal in a newborn, okay? Let me just send that to everybody. Okay. All right, perfectly normal in a newborn. All right, so our fetus is out. The uterine wall has to be sutured closed layer by layer, and then the abdominal incision has to be closed. So there are a couple of ways that this can be done. It might be sutures, it might be steri strips. Some places are using what we call the skin glue and staples. I would say sutures and staples are most common, usually with steri strips on top. So this is what a stapled cesarean, post-cesarean uterine incision looks like. And what type of incision is this?
Finestio bikini.
Right, the low transverse. This is a low transverse incision. So after the staples have been removed, very often the surgeon will place the steri strips, which are these steri strips, to hold the incision in place. So as it's completing its approximation, and usually steri strips will fall off. Did you guys talk about steri strips and fundamentals?
No.
Okay, so usually they will fall off as the wound heals. They will fall off on their own. They usually fall off on their own, okay? So those are your staples, steri strips. Both of those are low transverse incisions. Okay, so moms who are delivering by cesarean, we need to always consider emotional support. Sometimes these are not planned cesarean deliveries. It might be that she came in and she was in labor, and then the labor went into dystocia. It didn't progress, it became problematic. So she might be very disappointed. It might be a plan. Maybe this was a known CPD because during her prenatal care course, she was already informed that the size of the baby's head is not matching her pelvis and she's going to have a cesarean. She might be perfectly prepared for it emotionally. She might not be. This might be an emergency. So emotional support, patient and family teaching, promoting safety always, post-op care. I always encourage, and in my own practice, I always give patients kind of an idea of what to expect when they, after the surgery, when they wake up from anesthesia, or when they're in the recovery room, so that they kind of, they're going to forget most of what you say, but at least you have given them an idea of what to expect. And certainly you let the family know what they should expect so that they're not surprised by, what's going on. So TOLAC and VBAC, please add these to your abbreviation lists. TOLAC is a trial of labor after cesarean. So you might have a mom that is, let's say you have a mom that's G2, her first pregnancy resulted in a term baby that was born by C-section, let's say for CPD. And so now this is the second pregnancy. This baby seems to be a little bit smaller, is in proportion to the size of her pelvis. The obstetrician might determine that it is safe to give her a trial of labor to see if her uterus can tolerate the stress of labor. Okay, so trial of labor after cesarean. All right, that's what a TOLAC is. And a VBAC is a vaginal birth after cesarean. So a TOLAC might result in a VBAC. But the patient has to, every patient that has had a cesarean, the obstetrician will evaluate the likelihood, the possibility of a VBAC, okay?
Professor, I don't really understand the TOLAC or what.
Trial of labor after cesarean. Did you understand what I had mentioned previously about the risk of the uterus not tolerating the stress of labor?
Yes, but I don't understand why they would put, you're saying they would induce labor after?
I didn't say induce. She goes in, they would allow her to go into labor, and let's see if the uterus can tolerate it.
But
if she can tolerate it,
right?
I'm sorry?
But this is after she delivered the baby.
No.
So what I said was, this is trial of labor after cesarean. So the example that I gave you, she's a G2 mom, right? First pregnancy resulted in a cesarean delivery. This is the second pregnancy. Let's say she delivered a baby in 2015, okay? She had a C-section in 2015. Now this is the second pregnancy. The obstetrician determines that her uterus is probably strong enough that it should be able to tolerate the stress of labor. So he will give her a trial of labor. Let's let the labor start. She's in labor. Let's see how this goes. But at the very first sign that she's in any distress, then he might resort to delivering her by cesarean delivery.
So it's right before the C-section.
It is before the C-section. It's for this pregnancy.
Okay, and
It only applies to a mom that has had a cesarean previously in her past.
Right. Okay, so they don't give meds. They just let it happen naturally and they just observe it and then.
Correct.
Just make sure. Okay, thank you.
All right, let me just see what's in the chat box. Right. Okay. All right, so we're good with our cesarean delivery? Okay, so on to our vaginal delivery. All right, so for vaginal delivery, we honestly do not know what causes labor. There are theories regarding the onset, what stimulates labor, but we don't know definitely. It might be one of these, it might be a combination of these. So it might be that the progesterone levels, maternal progesterone levels start to decrease, the estrogen increases. Remember that the progesterone is what was keeping the uterus muscle calm and not contracting. It might be the release of prostaglandins, natural oxytocin. Remember, the body's oxytocin is what makes the uterus contract. If the receptors on the uterus are now more in tuned, more receptive to the impact of oxytocin, you're going to have more contractions. Stretching and pressure on the uterus and cervix from the progression of the pregnancy, and then of course increased fetal cortisol levels. So any of those, all of those can be a combination.
I have a question.
Let me just answer the one in the chat box, and then sexual intercourse can stimulate labor because of the prostaglandins in semen. Okay. So with everything, there's always a cultural aspect. So again, remember last week when I said for some cultures, sexual activity is taboo. For some cultures, it is not. So there's always a cultural aspect to that. Fred, what was your question?
I was just going to ask, what do they give to induce labor?
A whole bunch of stuff that we're going to talk about on Tuesday.
Okay.
Okay. Trust me, we will get to it, but
I'm sure you will.
Okay, so signs that labor is happening. So again, these are things that you need to include in your prenatal teaching. Remember how I said every visit we're always teaching patients anyway. Certainly in maternity care, every prenatal visit there should be teaching, not just about what is happening, but about what's coming. What's the next step? What's the next changes? What you need to be concerned about? This is what you need to be aware of. If this happens, you need to come in and see the doctor, that sort of thing. So lightning we've talked about, which happens at 36 weeks. Fetus dropping from the abdominal cavity into the pelvic cavity. There may be an increase in backache, again, due to that shift. There may be energy spurts. A lot of moms will have an energy spurt, and very often that energy spurt will result in nesting, those nesting activities that we spoke about last week.
Mm-hmm.
Braxton Hicks contractions are considered false contractions, for kind of practice labor, very often quote unquote called practice labor, like the uterine muscle is practicing for the more intense actual contractions of labor. Cervical changes we're going to talk about in a few minutes, but just so that you know that, and I will mention this again, cervical changes are the what really determines what cervical changes really distinguish false labor from true labor. False labor from true labor. I'm going to talk about the mucus plug right now. So, bloody show. What is bloody show? So remember last week we talked about the operculum, the mucus plug? Okay. When, again, with cervical changes, once the cervix starts to dilate, we'll talk more about this, so we'll stress on it. The cervix starts to dilate, the operculum will become dislodged. The mucus plug will become dislodged. When it is dislodged and disengages and removes from the body, the way it is anchored, it will rupture several of the surface capillaries. And so this bloody show is actually the mucus plug, the operculum, which is primarily mucus, and the bleeding from those surface capillaries. So that is what we commonly call bloody show. Okay, it's a mixture of mucus and blood. All right, and that is one of the signs of impending labor. Many moms will have a weight loss, 1 to 3 pounds weight loss. And it's kind of like the body, it goes along with this energy spurt. It's like the body is really getting ready for the work of labor. Some moms will have GI upset. So indigestion, diarrhea, nausea. Okay. So
when you, sorry, Professor, when you say the body's getting,
we're coming up to this point, and then we're going to talk about labor. Alice, what was your question?
Yeah, sorry. So when you say the body is getting ready for the work of labor, do you mean the metabolism is increasing, or
I mean the whole body? I mean the body is getting ready. Okay.
But why does that result in weight loss?
So that is the energy, the body is getting ready for the work of labor. So sometimes, and it's not a huge weight loss, it's just like 1 to 3 pounds. It's like the body is preparing for the work. So that any excess, and that is, it's between the increased energy level and the nesting activities that result in that weight loss. Okay, so there are a couple of things that I want you to start separating in your mind. Labor does not always mean delivery. We're talking about two different things here, okay? So labor being the coordinated sequence of involuntary uterine contractions, delivery being the actual event of birth, all right? So again, false labor versus true labor. So as I mentioned before, cervical change. So the last bullet on both sides of the slide, cervical change is the true determinants, is the determinant of true labor, okay? If there is cervical change, then this is truly labor, all right? So false labor, the contractions are inconsistent. They may change. If you have the mom lay down, they will tend to diminish. True labor, they are consistent, and the activity will not impact. It's hurting, it's going to hurt whether she's sitting, whether she's laying, it's going to be the same. But again, the true differentiation is cervical change. Okay, 3 stages of labor that, yes, you have to know. Stage 1, we're talking about cervical dilation and effacement. Stage 2, expulsion of the fetus. Stage 3, expulsion of the placenta. Stage 4, maternal physiologic stabilization. Okay, those are the 4 stages of labor. All right. So we'll talk about the changes to the maternal, that the maternal body goes through. We'll talk about the changes that the fetus encounters during labor, and then we're going to talk about some really specific things. Okay, characteristics of contractions. Contractions are coordinated, involuntary, and intermittent, okay? They are coordinated. They begin at the fundus, and then they progress downward. They begin at the fundus, they progress downward. They are involuntary, although they may be stimulated with physical activity. They may be exacerbated a bit with physical activity or with anxiety, with tension, which, as you know, makes your muscles tighter, and then pain is felt more acutely, but they are involuntary. Labor contractions are intermittent, or at least they should be, they better be. And we'll talk about the complications that what happens if they last too long. We'll talk about that tomorrow, okay? So they're intermittent. The uterus should contract and then relax. Contract and then relax. Okay. Those are the characteristics of contractions. Now, the contraction cycle. Contraction cycle, you have to know all of these parts of the cycle. Frequency, duration, intensity, resting interval, increment, acme, decrement. So the frequency of a contraction, contractions, the frequency is the beginning of one contraction to the beginning of the next contraction. So the frequency is how often are they happening? Beginning of one contraction to the beginning of the next contraction. And that may be timed in minutes, it may be timed in seconds, depends on what's going on, all right? So beginning of one to the beginning of the next. The duration is how long one contraction lasts. If you are reading many contractions, it might be the range of how long the contractions are lasting. So that usually is given in seconds. So the beginning to the end. The beginning to the end. The intensity just refers to the pain, so to speak, of the contraction. That is speaking to the intensity of the contraction. So whether it's mild, moderate, or strong. And I'll come back to intensity in a minute. The resting interval. This is the interval in between the contractions, the relaxation interval. So this is when the muscle actually relaxes in between the contractions. Oops, sorry. Okay. The increment. This is the buildup of the contraction. And then there's the peak of the contraction and the decrement, the letting down of the contraction. Okay. Release of the contraction. So again, you need to know the duration, how long it's lasting, what is the intensity, and what is the frequency of the contractions. So those are the components of the contraction cycle.
Question?
Yes.
You said peak, is that acme?
Yes, I'm sorry. I forgot I had acme on the slide. That is the peak of the contraction.
Okay.
There was another question?
Yeah, I was going to ask the same thing. Thank you.
Okay, you're welcome. Okay, so that's the contraction cycle. Now, the uterine body, how does the uterine body actually change? So the contractions begin in the fundus, and the way it happens is that the fundus actually thickens. The muscle actually thickens with the contractions. So you can see the top of the uterus becomes thicker. As the contractions happen, it actually, the fundus thickens and it actually pulls the muscle up a little bit. As that happens, the cervix dilates, the cervix opens. So when the contractions are effective, the fundus thickens, the lower uterus thins, and the cervix dilates. So effective contractions contribute to cervical dilation. So as you can see, we're going from this fundus, it's a little bit higher, it's starting to thicken, this is starting to thin, to the fundus being thick and the lower segment being thinner. The cervix is opening. Here, this where we started, the cervix was closed, it's opening, and then it's open. Okay?
Professor, I have a question.
Yes.
So I spent some time on a labor and delivery floor at my previous school, like for a volunteer thing. Why do they massage it at the end, like after?
After the delivery.
Yeah.
Do you mind if I answer that next week?
Oh, sure.
Only because that's a big part of postpartum, and we need to really talk about that. How it's done and why it's done and all that good stuff. So sure. If you can hold on to that question until next week, that isn't important. That's very important, but it's a next week. You and Fred are like way ahead of me here.
Only because I saw like one C-section and like a couple births.
Vaginal births, yeah. Frontal massage is it's a very important part of our postpartum care.
Okay.
Okay, so we're good on our uterine body changes, yes? All right. Blood flow changes. Blood flow changes. Oh, I think I underlined that because I don't have a picture to remind myself there was no picture for that. Okay. Blood flow changes. All right. Remember what we talked about, the blood flow through the umbilical cord. How rapid, how much blood flow is flowing through the umbilical cord. Now, with each contraction, 500 milliliters of blood leaves the uteroplacental unit and goes into the maternal circulation. So remember, we've talked about how important it is for the placenta to be perfused. The placenta has to be perfused for a fetus to get the oxygen and glucose that it needs. So when the contraction happens, 500 mLs of blood leaves the uteroplacental unit and goes into the maternal circulation. So during a contraction, what is our fetus getting as far as oxygen?
Less oxygen.
Less? Barely any, right? Barely any. Okay, so definitely less. Now, on the other hand, what does this mean for the mom's cardiovascular system?
It's increasing and improving her strength.
The volume is increasing, right?
Right. So the volume is increasing. So I want you to think about this. What if your mom is hypertensive?
That's going to keep on going up.
Right. What if your mom is hypertensive? What if this is the mom who in 2010 had a myocardial infarction? What if this is the mom who's had mitral valve replacement? What if this mom has any sort of cardiovascular issue? Every few minutes, she's getting this influx of volume, and then it diminishes, influx, diminishes. So that's taxing on the heart, all right? So when we get to complications and we start talking about how sometimes moms end up after labor and delivery, how they end up with chronic cardiac issues, this is how it happens, okay? So 500 mils of blood leaves the uteroplacental unit, goes into the maternal circulation. So my question to you is, when are you doing your vital signs in relationship to the contractions?
After.
The whole time.
She's contracting.
Doing it continuously?
So tell me if you're doing it during a contraction or between contractions.
During a contraction.
But if you're doing it during contractions, are you truly getting her baseline blood pressure?
No, I'm doing it before. Well, then you're between.
What you're getting, if you do it during a contraction, think about it. You're doing it when she's getting the influx of volume. So you're not truly getting her blood pressure. So you have to do them between. So if you have a mom that is contracting every 2 minutes, you might have to put the cuff on and then wait. You have to time this carefully, okay? So you have to time it carefully and pay attention to when the contractions are happening so that you're getting a true reading of her blood pressure, all right? So again, I want you to start thinking about what this means in relationship to your nursing care, how you're timing what you need to do, how you're doing your assessments. Okay. So remember here, when I said to you that the resting interval, we've got to have an adequate resting interval. This is why the resting interval is so important, because during the contractions, this is when the blood leaves the uteroplacental unit, which means the fetus is getting minimal oxygen. During the resting interval, that is when the uteroplacental unit reperfuses, and that's when the fetus gets oxygen. So if this is too short, the fetus is not going to get enough oxygen, and you're going to have a fetus that's in trouble, right? We're going to have fetal distress. So we need to make sure that the contraction doesn't last too long, that it's not peaking too high, that it's not happening too frequently, and that the resting interval is adequate, okay? We're going to talk a lot about that tomorrow, but I want you to start to understand that concept of how that factors into this fetus, how it factors into this whole labor and delivery process. All right. Okay. Where are we? Okay, so we did that. Okay, so questions about blood flow change before we talk about the cervical changes? We're good so far?
One question that is related to where we're going. You said it, and I saw it on an earlier slide, the cervical OS. What is OS?
The cervical os, the cervical opening. So this is the internal os. This is the external os. So the cervix is actually about 2 cms long. This is, and it has, there's like an os at the top and at the bottom. It's actually a little bit longer than we tend to think of it being.
Is os the word, or is it short for something?
I'm sorry?
Is os the word, or is it
It's the word. It's a full word.
Okay,
2 letters, but it's a full word. Yes. Cervical os. Yes. Sorry.
Oh, good.
Okay. An anatomy thing. Okay. So cervical changes. When we talk about effacement, we're talking about thinning and shortening of the cervix. So this is the cervix full length, not effaced. This is the cervix fully effaced. So we are actually going from 2 cms to paper thin. Okay, so when the cervix is not effaced, 2 cms. When it's fully effaced, paper thin. Okay, so when we talk about effacement, we use percentages. So we will say that this cervix is 0% effaced. This is 100% effaced. So fully effaced. So remember, effacement being thinning. So if it's 100% effaced, it's 100% thin. It's completely thin. This is 0, not effaced, 0%. Fully effaced, 100%. So what would you say the percentage is here? So I'm just going to ask you to put it in the chat box. What would you say the percentage of effacement is here? And it's not fully, it says fully here, but it's not fully, as you can see. I would say more than that. So remember, you're going from this to this. If this is 100 and this is 0, I would say this is probably about 30%, 30, 40%. Yeah, about 30, 40%.
So you're talking about how thin it is, not how big the opening is. I got you.
Thin, right. Thin. Vertically, in terms of vertically thin. Okay. One second, I have to plug my computer in. My battery just went dead. It's trying to go dead. Okay, so questions about effacement?
Yes.
All right.
Professor, yes. So it doesn't always correlate with your dilation, correct?
No, okay. 2 separate things, yes. Okay, dilation. When we talk about dilation, we're talking about the opening of the cervical os. The opening of the cervical os. So, not dilated, it is closed. So it's 0 cms. Fully dilated, 10 cms. So we're going from 0 to 10 cms. So some fruits to give you a reference point. I think I gave you this slide, did I?
Yes, you did.
Okay. So if I tell you that your patient is okay, this is what I tell you about your patient in the chat box. What's your thought? Are we on our way to having this baby, or are we like, we're going to be here all day? What are you thinking? So first of all, what does that mean? So I see halfway and I see not yet. So 5 cms refers to what? Dilation or effacement?
Dilation.
Dilation.
Dilation. And 80% refers to effacement. So I want you to remember that the two of them don't always correlate. So you're not going to see 5 cms 50%, 6 cms 60%. Doesn't happen like that, right? The body does what the body does. So she is halfway, yes, halfway dilated and almost fully effaced. Almost fully effaced. Okay.
You have to wait for both of those things to get to completion before.
Absolutely. So I'm going to come to that in just a second. So I want you to remember that you might easily see this, and you would need to interpret that. Okay. You need to know which is referring to dilation, which is referring to effacement, that 5 means cms, and that 80 means 80%. Okay. Now, in terms of labor and delivery, and we will talk more about this a little bit later, you definitely want to make sure that she is fully dilated and fully effaced before she begins to push. So remember a few slides back, I said this was stage 1. Stage 1, cervical dilation and effacement. So stage 1 will end when we are 10 cms dilated and 100% effaced. And at that point, we're ready to go into stage 2 and begin pushing to expel this fetus. Remember that the cervix is very, very vascular. A mom that's pushing against a cervix that is not fully dilated or effaced, that cervix can lacerate and can cause a significant amount of blood loss, essentially of hemorrhage, okay? That we don't want, all right?
Professor.
Okay, yes.
Professor Simona here. Is it the moment to ask you, how can